Hello, my name is Christine Park and I'll be talking about consideration of osteoporosis and spine surgery. This is the outline I'll follow in my presentation. The goal at the end of this lecture is to allow the listeners to understand the basic mechanism underlying bone homeostasis and appreciate the importance of osteoporosis in individuals undergoing spine surgery. So a little bit of background. Osteoporosis is primarily considered an age-related disease. In the next few decades, the elderly population will increase by approximately 8%. And combined with an increasing life expectancy, the prevalence of osteoporosis among spine surgery patients will also increase. And spine surgery is challenging in osteoporotic patients because aging spine increases the risk of compression fractures and frequency of instrumentation failure due to decreased bone mineral density. Hence, the benefit of spine surgery becomes more complicated in this patient population. Despite the important role that osteoporosis and bone quality play in determining surgery outcomes, many spine surgeons do not screen for osteoporosis, and hence screening should be of utmost importance when evaluating patients to serve as a guide for arranging optimal preoperative management and surgical strategy. And so there are three key phases of bone homeostasis: resorption, reversal, and formation. So during resorption, rank proteins on the surface of precursor osteoclasts are activated by rank L expressed on the surface of osteoblasts, resulting in maturation of pre-osteoclasts to osteoclasts. And this in turn promotes increased resorption of bone by the osteoclasts, and eventually these osteoclasts are replaced by mononuclear cells in the reversal phase and produce cytokines which promote the migration of osteoblasts. And finally, the osteoblasts produce new woven bone in the formation phase to reform the bone matrix. And throughout this cycle, calcium, vitamin D, and parathyroid hormone contribute to the maintenance of overall bone health. So the WHO has established diagnostic criteria for osteoporosis based on BMD, which is evaluated using a DEXA scan, usually in the spine or hip. If the BMD cannot be determined from the spine or hip due to physical limitations such as obesity, or if the patient has any degenerative spinal changes which can falsely elevate the BMD, DEXA scan can be performed on the radius in the distal forearm. A patient's BMD on a DEXA scan is compared to that of a healthy 30-year-old adult of the same sex and ethnicity in a site-specific manner to generate a T-score, which is used to classify osteoporosis. So as shown in the table below, a T-score of greater than -1 is considered normal. A T-score between -1 and -2.5 is defined as osteopenia, and any T-score less than or equal to -2.5 is considered osteoporosis, and any T-score less than or equal to -2.5 with fracture is considered severe osteoporosis. So the American College of Radiology recommends asymptomatic screening in 1. Women age 65 and older, 2. Younger women with additional risk factors for osteoporosis such as estrogen deficiency, low body mass, history of amenorrhea, smoking status, and loss of height, thoracic kyphosis, and 3. Men aged 70 and older. And because BMD strongly correlates with fracture risk, most risk assessment tools utilize BMD measurements to determine the risk of osteoporosis. However, BMD has low sensitivity because most fractures occur in patients with BMD T-scores that do not meet the current definitions for osteoporosis. But BMD independent clinical risk factors such as age, sex, past medical history of fracture are fracture risk factors that can help predict the likelihood of osteoporosis. There are other predictors of osteoporosis, such as Hounsfield unit, which is a CT attenuation number that has been proven to correlate well with BMD. So now I'll talk about some prevention and treatment options for osteoporosis. The first line modality for conservative management of osteoporosis is supplementing a patient's nutrition with calcium and vitamin D. As you well know, calcium is an important component of bone structure, and it could serve as a supplement for improving bone health. Vitamin D enhances calcium absorption and can also improve the overall bone health. And next we have bisphosphonates, which are the first line treatment for osteoporosis. They can help prevent bone resorption by inhibiting osteoclast activity and inducing osteoclast apoptosis. Next, we have teriparatide, which consists of the first 34 amino acids, which are considered the bioactive part of the endogenous parathyroid hormone, and it enhances the number of osteoclasts and osteoblasts, increasing bone remodeling and bone strength. And intermittent administration results in transient increase in plasma calcium concentration, which in turn stimulates osteoblast activity more than osteoclast and thus favors formation of new bone. And teriparatide is the only treatment for osteoporosis that actually builds bone. And decreased level of estrogen is the reason behind poor bone quality and increased risk of osteoporosis in postmenopausal women. And so both hormone replacement with estrogen and use of selective estrogen receptor modulators inhibit bone turnover that subsequently decreases the loss of bone density over time. And then next, calcitonin is usually given for managing pain associated with osteoporosis. And denosumab is the only FDA-approved human monoclonal antibody for the treatment of osteoporosis. And it binds to the surface receptor RANKL on osteoblasts, preventing RANKL binding to the RANK receptor on the surface of pre-osteoclast and consequently inhibiting its conversion to osteoclast. So the effect of osteoporosis on surgical implications is that despite many options available for treating osteoporosis, there's no clear data and guidelines for managing individuals with osteoporosis who are undergoing spine surgery. Hence, it is important to consider screening these patients suspected of osteoporosis to optimize preoperative management and guide surgical strategy. So this is the screening and treatment algorithm for patients undergoing or considering spine surgery. So for a patient with a history of osteoporosis or multi-level instrumentation or is of age greater than 65, we recommend the patient undergo DEXA testing. And if the patient's BMD is normal or is a T-score of greater than -1, then we can proceed with the planned instrumented spinal surgery. However, if the patient has low BMD or a T-score of less than or equal to -1, then we ask the question of whether or not the patient can tolerate postponement of surgical treatment. If the answer is yes, then we would start the patient on teriparatide or bisphosphonate, and then after a certain period of appropriate length of treatment, then we would proceed with instrumented spinal surgery. And then after surgery, we would consult with endocrine to continue postoperative medical management of bone density. However, if the patient cannot tolerate any delay in surgical treatment, then we would first proceed with instrumented spinal surgery, and then we would start the patient on teriparatide or bisphosphonate or any other appropriate osteoporosis medications that were introduced in the table in the previous slides. So in conclusion, in the currently aging population, osteoporosis is becoming increasingly prevalent, and this is because weakened bone predisposes individuals to elevated risk of fracture and degeneration. And even though there are numerous well-established therapeutic options for osteoporosis available on the market, further research has to be done to prove their definitive benefit for patients, especially the older cohort. And more research efforts need to be focused on elucidating the effect of available medications on patients undergoing spine surgery so that appropriate screening and treatment guidelines can be developed to achieve successful surgical outcomes.